Good afternoon, Dr. Purender, Dr. Mahipal, sir. We are just about to start the session, so nice to have you with us.
Very good afternoon, Dr. Manpreet, and really appreciate to involve in this RPC 58th anniversary program.
Good afternoon, everyone. I, Dr. Akshara, a senior resident from RP Center, invite you all for 58th Foundation Day celebration. Today, our session is on emerging trends in ophthalmology, and we will begin our session with the talk by Dr. Manpreet on next generation IOL materials in new generation material, our experience. Over to you, ma'am.
Thank you, Dr. Akshara. I also take this opportunity to welcome one and all for the 58th Annual Foundation Day celebration. So these are our virtual sessions, and we hope we are able to reach a lot of ophthalmologists across the country and abroad for this. So I'll just share my screen. Okay. So new generation, new IOL materials in the next generation IOLs. I'll be talking about our experience with the Clarion platform. There are no financial disclosures. So evolving IOL technology has involved a lot of modifications in the IOL surface, the square edge design, UV absorbing materials, bioactive materials, and increased capsular and UV biocompatibility. So it has been aimed towards decreasing the incision size and providing optimal visual acuity while minimizing the incidence of posterior capsular opacification. So we went from PMMA to silicon to hydrophilic, and hydrophobic has been the mainstay since a lot many years now. So the pros of PMA was, of course, optical clarity. However, it was a rigid IOL. Then silicon oils, though foldable, were prone to discoloration, inflammation, and calcification issues. Hydrophilic had a high hydrophilic water content, so there was less glistening. However, there were thicker lenses with internal and external calcification and a much higher incidence of PCO. So hydrophobic acrylic with their truncated edge design were very resistant to posterior capsular opacification. The cons were the incidence of glistening, surface haze, and dysphotopsia. So the new IOL material should ideally combine the best of the hydrophobic and hygroscopic features. So the hygroscopic component is going to have the desired equilibrium of water content, which is important to reduce glistening, and the hydrophobic component will allow flexibility and control the refractive index for the clarity. So Clarion is an advanced foldable single piece PCIL which significantly has lower edge glare and lower incidence of PCO and subsequent YAG rates. And in fact, the Clarion autonomy platform is a single use preloaded delivery system using a carbon dioxide gas driven mechanism which enables precise delivery through incisions as small as 2.2 mm. So it's a hydrophobic acrylate methacrylate copolymer with a refractive index of 1.55. The water content is slightly higher than the previous Alcon lenses, which gives it more clarity, less glistening, less surface haze. And the sharp posterior edge, of course, minimizes PCO and minimizes dysphotopsias. Excellent centration and stability with the stable force haptics. So what we did was performed an interventional prospective post-market single-arm unmasked multicentric study with a 12 months follow-up with Clarion autonomy device. A total of 151 eyes were included at 7 different sites. It's even published now. So the primary endpoint was the best corrected distance visual acuity monocularly of 0.2 logmar or better at 1 month. Then of course there were secondary endpoints, the surgeon preference for autonomy device and safety endpoints including device deficiencies and PCO rate. So what we observed was that more than 94.7% of the eyes met the primary endpoint of 0.2 logmar or better visual acuity at 1 month. And in fact, in the first time, 98% had 0.2 logmar or better. When we come to the safety endpoints, the delivery system issue like loss of power, trap trailing haptic or sudden injection was seen only in one eye, and difficulty in folding or unfolding of the IOL in 4 eyes. As far as we were concerned, we did not observe any difficulty in IOL delivery or unfolding and no intraoperative complication per se. So this is just a surgical video. So you load it, put in a dispersive OVD. Viscot is what's recommended by the manufacturers, and just fill the cartridge up till the point, the line over here. After that, you just remove the plunger and just click to activate the carbon dioxide delivery system, and the lens preloads itself beautifully with the leading haptic folding upon the optic. It's a wound assisted delivery system that easily allows insertion of the IOL through the 2.2 mm incision without any need for enlarging it. And in fact, you can implant the IOL directly in the bag. There is no need to tuck it with a Sinsky or anything. It goes completely in the bag. After that, OVD removal, etc., is simple. So, what did the surgeon say? 42.9% found it much easier than their currently used delivery system, and 42.9% strongly agreed that they preferred it over their currently used IL and delivery system. And if you look at recommend and strongly recommend, almost everyone, 100% would recommend this device to their colleagues. So, coming to surface haze, we did not report any surface as haze at any of our visits. The lens was crystal clear. It's a delight to actually see it in the post-operative period. Eye glistening, no significant eye glistening was observed in any of our cases till the last follow-up in the study, and now we have follow-up of years, and the lens is doing beautifully. No significant posterior capsular opacification till 1 year. Mild peripheral posterior capsular opacification may be observed, of course, but the lens does remain beautifully clear. Modulation transfer function and point front function are excellent because it's a monofocal eye, so there are no aberrations induced by the intraocular lens. So to conclude, the Clarion Autonomy is a preloaded delivery device that allows means to insert the IL into the capsular bag in a controlled manner. And at 1 month, 98% of the first eye and 94.7% of the second eyes achieved the primary endpoint of 0.2 logmar or better. There were no significant IL glistening, surface haze, or visually significant posterior capsular opacification till 1 year of follow-up. And in fact, this Clarion material is now available across the range of the IOLs, including Panoptix, Vivity, Vivity Toric, Panoptix Toric, and Clarion Toric. You either have preloaded, which is the Clarion monofocal with the autonomy carbon dioxide delivery system, or you can use your conventional Monarch cartridge and autosert or manual injections. Thank you for a patient hearing.
Thank you so much, ma'am, for this wonderful talk. I would next request Dr. Sridevi Nair for her talk on emerging trends in physiological IOP phacoemulsification. Over to you, ma'am.
Good afternoon, everyone. I'll just share my screen. Yeah. So I hope my screen is visible.
Yes, it's visible.
Yeah, I'm just trying to. Yeah. So is it on the slideshow mode, I guess? So I'll be speaking on the emerging trends in physiological IOP phacoemulsification. I am Dr. Sridevi Nair, an assistant professor at RP Center, Cornea, Cataract and Refractive Surgery Services. So evolution of phacofluidics has been evolving since at least the last 2 to 3 decades, wherein we've had gravity fluidics, which were very popular up to 2 decades earlier, followed by hyper pressurized fluidics, wherein an air pump was used to achieve the high irrigation pressure, followed by the active fluidics technology, which was a real game changer, which allowed the surgeon to fix and maintain the IOP in the eye, irrespective of what the irrigation flow rate was and what the aspiration flow rate was. And then now we have the active fluidics technology with the active sentry, which is one step ahead of this. And this basically has an irrigation pressure sensor within the handpiece, which gives a real-time feedback of the intraocular pressure in the eye. And it transmits this to the machine, the software and the hardware, which then changes or modifies the intraocular pressure and keeps it constant based on the requirement. So it has an integrated sensor which dynamically measures the eye pressure, and it is placed very close to the eye, of course, because it's in the handpiece, and it enables precise and timely iopic measurement. And also so this basically alerts the active fluid technology which is there in the cassette or in the hardware and software of the machine, and any fluctuation that occurs in the anterior chamber, it immediately triggers adjustments which is designed to stabilize the anterior chamber and ensure consistency. So
I'm not
basically,
able
this
to see
allows.
your slides.
Uh,
It's only the intro slide which is there,
okay,
Dr. Sridevi.
wait, I'll just check again. Okay, is it okay now? No?
It's not in the slideshow mode somehow.
Okay, I'll just check again. Yes, it's actually on the, wait.
You can
I'll,
switch off the presenter view in case you're using that.
yeah, no, I'm not.
That
I'll
causes
just
issues.
check it again.
Just check it again.
Yeah. Is it better now? Now can you see the slide with
Yeah.
active century advantage? Yeah.
Yes.
So basically what I just said in the previous slide, how it works is that, so this is the handpiece of the active sentry, which has a pressure sensor, which, as I said, is located so very close to the eye. So it can dynamically detect the eye pressure changes, which then transmits this message to the software of the and the hardware of the machine, which has a quick valve technology. So this quick valve technology, based on the changes in the eye pressure, will push in more fluid into your irrigation line, and this will help maintain the pressure of the eye. So also there is so as compared to the Infinity phaco machine, which we've been using before, which was based on gravity fluidics, it had a single pump. And as we can see, the Centurion, the newer one, has a dual pump, which basically ensures that there is no time when the vacuum is not maintained. So this really reduces the lag between the time of when your vacuum changes from a certain point to the next point. Also, as you can see, there are 7 rollers in the peristaltic pump with the Centurion. So this allows for a smoother and faster fluidic response. We can look at this graph, which shows you the non-occlusion vacuum variation, which is very low with the Centurion machine because of this dual pump and the high number of rollers, as opposed to your earlier Infinity machine. The next advantage with active sentry, as we said, is the chamber stability. So this is for all your cases, and this basically translates you to allowing performing the surgery at lower or more physiological IOPs. So people have done surgeries at as low as 20 and 30 mmHg, which basically ensures greater patient comfort, which will translate to greater surgeon comfort. So if you can see that as the IOP changes occur in the anterior chamber, the active fluidic technology actively works to maintain the target IOP. So if you look at this graph, in the gravity fluidics, you can see that as the aspiration rate increases, when it's nearly 40, the actual IOP has gone down from where we started at around 70 to below 40. So it is like just at 40. And this is a very significant change, as opposed to an active fluidic system with Centurion, which has remained constant throughout the change in the aspiration rate. Similarly, if you look at the IOP and the aspiration flow rate in a pressurized irrigation system such as a Stellaris machine, again, you can see that it is not very stable, and there is a significant decrease as you increase the aspiration rate. And the next advantage is that, so one is that you can have a stable IOP during your cases, and the next is surge mitigation. So surge is a common problem that we encounter in our cases, especially when we do the harder cataracts. And now if you look at, so basically this mechanism which allows us to maintain the IOP of the eye in a real-time scenario helps in surge mitigation, and especially the valve technology that we discussed earlier. So if you look at this graph where you have the surge eye volume, the simulated eye volume after an occlusion break, which basically shows you how much volume has been removed from the eye. And in cases of the Infinity one, which is the lower, the gray one, it is much more the volume loss, and also the time to recovery is also much longer. So it's nearly a second or a little less than that, as opposed to Centurion, where the drop is much less and the recovery is much faster. And similarly, surge mitigation as well. So if you look at the surge volume, which is in cases of Infinity, if you reach the vacuum of around 600, 650, the surge volume increases to 0.12, which is quite high at a set IOP point. Whereas in case of Centurion, up to 600, it is pretty much constant. And so what the Infinity was giving you at a 300 vacuum, the Centurion would be as constant as a 600 vacuum. And the next major advantage is that there is a very good IOP ramp, which basically ensures that the IOP rise in the eye is gradual. So it ensures that the patient does not feel any discomfort. This is particularly useful when you're operating high myope cases, wherein the anterior chamber volume is generally high. So there is a sudden increase of a sudden rush of fluid to increase IOP. The patient is known to have pain, etc., especially when you operate under topical. And then another advantage with this machine is that the IOP that is maintained is irrespective of the patient eye level. So unlike the gravity fluidics, where it's important that it is respective of the patient eye level when you look at the IOP, the sensors in the Centurion machine ensure that the IOP is maintained and there is no need for manual adjustments in these cases. The irrigation factor, again in this case, so when sometimes your wound, when you make it 2.2, you might increase it slightly to 2.4, maybe to inject the IOL or just like that, and that leads to some fluid leakage. Again, this machine, it will detect the fluid loss and it will help you maintain it. And it doesn't matter whether you've increased your incisions slightly, whether it's for IOL implantation or otherwise. It has a controlled performance across a variety of vacuum levels, as we can see, whether it's a phakic eye or an aphakic eye. So the loss of aqueous volume during the surgery at different vacuum levels is less than 30% consistently, which is very good. And the next we come to is that, and other than the fluidics, the other important thing is the phaco tip. So the balance tip, it offers a very good advantage of more lateral movement, so which basically decreases the movements at the incision site, and it also increases the efficiency at your phaco site. So that leads to the advantages of enhanced torsional efficiency, reduced repulsion, reduced energy output, and less fluid use. So basically, it amounts to a faster phaco and an accelerated cataract removal with less energy being used. The next safety parameters that it enhances is the temperature. So the temperature rise with this machine is much lower than your other phaco modalities, and that, as we can see with these graphs, is much lower, which basically translate to less temperature rise and more endothelial safety, etc. Again, if you look at the enhanced surgical and time efficiency, so the aspiration time is much lower, the cumulative dissipated energy is much lower, and the aspiration fluid volume used is also much lower. So to summarize, the active sentry, it has the advantage of increasing the efficiency, consistency, and safety. It reduces the surge, it maintains the target IOP regardless of the patient eye level, maintains the stability across a variety of vacuum levels, reduces phaco procedure times, and protects the eye from heat injury. Thank you.
Thank you so much, ma'am. I would like to ask you, in your experience, which cases benefit from active sentry technology specifically?
Yes. So as I just mentioned, that any case such as one is the high myopes, so that in those cases there is a major advantage. Other than that, if there is a floppy iris, so cases with floppy iris, again maintaining a constant pressure is the challenge, and you don't you want kind of like low flow parameters in those cases. Then again, cases like posterior polar cataracts, where you want the chamber stability because your PC, if your PC is weak for any reason, maybe it's because of a lens touch during a pars plana vitrectomy, or if it's a polar cataract, in all of these cases, a stable chamber will help you increase the safety as well. And of course, in all your routine cases, because why do you want to be slow and less efficient? So it's for all cases, but yeah, these are some of the situations where it really has specific advantages.
Thank you, ma'am.
Yeah.
I would next invite Dr. Purendra Bhasin for his talk on phacoemulsification in post-RK eyes.
Thank you, Dr. Radhika ma'am, and all the chairpersons, and I am really happy to be part of this ophthalmic scientific fiesta, the 58th Foundation Day ceremony. I will be speaking on pearls for phaco in post-refractive cases. This will include SMILE and LASIK, etc. also. But my focus will be on post-RK cases. I don't have any financial interest. So the issues with these all cases are post-refractive cases are that the most important problem is the inaccurate IL power calculation. Secondly, the RK incisions, they create a challenge during the cataract surgery, which I will be dealing with in my talk now. And the post-operative recovery can be prolonged, and there are very high chances of residual refractive error because of the inaccurate IL power calculation. So, why there is an inaccuracy in the IL power calculation post-corneal refractive surgery, which includes RK, LASIK, PRK, and SMILE? Like in RK cases, which now all these patients, they come to us with the cataract, and in the past, a lot of patients have undergone RK. And so because the anterior and posterior corneal, both corneal surfaces, they are flattened as compared to LASIK, which flattens mainly the anterior surface. So in this, the calculation of IL power post LASIK is more difficult as compared to the post RK cases, because anterior and posterior surfaces, they flatten in unison. The second thing is that the optic zone diameter in RK is significantly smaller and smaller than the measurement zone of the standard keratometers which we are using, which takes into consideration around 3.2 millimeter. But here the optical zone has decreased to less than 2 millimeter or 1.5 millimeters or so. The another important issue is the keratometric index, which we use for the IL power calculation, is no longer valid because of the change in the physiological anterior posterior curvature, which is now disrupted. So this 1.3375, which the KI which we use, is no longer valid for the IL power calculation in the older generation formula. Due to this, the effective lens position is erroneously predicted in a different way, anterior in the flat cornea, and deeper posterior in the steep cornea. So that's why the third generation IL power calculation formula will lead to a lot of problems in the IL power calculation. And due to all this, there is an overestimation of the corneal power, which we calculate, which results in implantation of the undercorrection or the lower power of IOL, which we are using. So that's why the hyperopic or refractive error is left over, both in LASIK and post RK cases. Uh, and the axial length measurements by optical biometer improves the precision. So, so we should use the corneal IL formulas, like which doesn't consider the corneal power to infer the effective lens position, like the Hagizel and Shamas. And in the past, we were using the double K Arambari S3 formula, which used to give us quite accurate IL power calculation in post RK and post LASIK eyes. But at present, what I will say is that Barrett True K formula is good and predictable. This holds true both for post myopic and post hyperopic, but post myopic, it is much more accurate. The intraoperative aberrometer can also be used, and ORA and OCT-based IL formulas, like which are present in RTView, OptiView, they can also be used, but with the inferior results. Multiple keratometry readings, if you don't have the Barrett True Care formula using the biometers, then multiple keratometry reading within the central 2 to 3 millimeter zone will give us some idea. And with the Pentacam or Galilei, which take into consideration both anterior and posterior curvature of the cornea. So this will land you to near normal IL power calculation. And we should always use the flattest K reading, and we should target myopic side, and we should always aim for higher power calculation. Like if it is coming 20 diopters, then we should plan for 20.5 diopters or 20.75 diopters in all these cases. Coming to the post-smile cases, the limited studies are available, but Barrett, Ruke, or Oculex or Mascot formula can be used. What I am presently using for last more than 1.5 years, because this IL Master 700 we used for last 3.5 years, we are using it. And here you can see that this can consider post LASIK eye, and this formula will give us the power which has to be used, and true K power is given, and cylindrical power is also available to us. and we can correct the cylindrical power as well as the refractive error. This is quite close to the normal power, and we have used it and find it to be more accurate. Otherwise, if you don't have IL Master 700 or equivalent the biometers, then one can use ASCRS IL calculator, which takes into consideration the optical and ultrasound biometric data as well, and keratometry data as well. And this also is comparable but less accurate than the Barrett's 2K formula. Coming to the surgical consideration in post-RKIs, because of these incisions, which are 95 to 95% thick, involves the thickness of the cornea, they are weak and are prone to open up during the surgery. And one should avoid intersecting uh, cataract surgery incisions with the existing RK incision, as they can get unzip and open up and cause problems during the surgery, which I will be showing in a video now. With more than 8 RK cuts, it becomes difficult to avoid intersecting existing RK incision. So what I prefer, I do is I make a 2.2 millimeter scleral tunnel cataract incision, and this will take care of everything, and there is no harm to the existing RK incision. It is preferred to use a smaller phaco needle, lower flow rate, and lower bottle height, like lower IOP, as has been said by Dr. Nair also, to ensure safe surgery procedure. And just to give you this thing, that we can have a nightmare, and there is a high chance of globe rupture in these high myopic eyes with the posterior staphylomas. So this is my first case, which has a cylindrical power of true K power is minus 5.84 diopter at 113 degree. And we are using the laser vision correction post RK formula, and the IL power is 24 diopters, and rather we will be using 24 and a half diopters. And this is the calculation which we get. This is the post RK picture on the right side. This we are using, and this is the online toric calculator, which gives us, we have to use a T9 power at aligned to be aligned at 14 degrees, and there is a anticipated residual refractive error because the power of the cylinder was very high, more than 5 diopters. So this is the surgery of this patient, and we are making the side port incision. We can use no side port incision also, but I prefer using bimanual. So here I have made a scleral tunnel incision because there are more than 16 RK cuts. And another thing is that some people say that flax cannot be, laser assisted cataract surgery cannot be done in the post RK eyes because of the incision. There is a high chance that the capsular axis will become incomplete. But in this particular case, as you can see, my capsular axis came out in a single piece, and there is we have to be careful, but there is a less chance that there is interruption in the capsular axis. Phacoemulsification is done at low parameters. I use 34 millimeter mercury intraocular pressure in all my cases. Bimanual incisions, I am doing bimanual irrigation aspiration in a normal way. My incisions are in between the RK incision, pre-existing RK incision, and the scleral tunnel part is taking care of the ripping or unzipping of the pre-existing RK incision. I am removing the viscoelastic, and at the same time I am aligning it to 14 degree, which was the anticipated side, and this is 14 degree. And at this point, if you see that while doing the hydration of the wounds, there is a overhydration, and there is a swelling up of the post RK incision. So you can leave air in the anterior chamber at the end to prevent the leakage. So this is the case. Another case wherein I have not been careful, and my incisions are in the cornea, and there is a leak of the wound, a pre-existing RK wound, but I am fortunate enough that it is being plugged by the iris here, and this has happened at during the irrigation aspiration only, and lucky enough that I could escape that this didn't happen during the phacoemulsification. And low parameters is very, very important. At the end, I will give a circumferential the suture to this radial cut, which will not seal otherwise and will leave a leakage, wound leak, and I will leave. So this is how it was managed. So this can happen if it is not properly, the main incision is not a scleral incision. So this is another case wherein there are only 8 cuts. So in such a condition, you can place your the main wound, phaco wound, in between the two RK marks. And this is again post laser cataract surgery, and phacoemulsification is done, and there is, because the incision is lying between the two RK marks, so there is no chance that this is intersecting the RK marks, and there is less chance of zipping up of the RK incisions. So rest is as everyone does it. The lens is placed in the bag, and I prefer the aspheric lenses. This is another interesting case with multiple incision, and but there is a coexisting microcornea. The corneal diameter is less than 8 millimeter. So again, I am making a scleral tunnel wound, although it has covered almost two RK incisions. So to avoid the ballooning of the conjunctiva by the reverse of fluid from the main incision, I just make a cut. I just cut the conjunctiva adjacent to the scleral wound which we have made, and capsular access is done, hydrodissection, and rest surgery is same. Only thing is that our capsular access in this cases should not go along with the size of the diameter of the cornea. Capsular access should be 5 millimeter, which should be marked and then made. Otherwise, you will end up in a small capsular axis, and the lens will become decentered and fluctuate. The lens bag will become contracted because of the small capsular axis. Rest is same. So post-operatively, these RK incisions, they can swell up during the cataract surgery and can induce central corneal flattening. And this results in excessive hyperopia in immediate post-operative period. So if your volume of fluid which is used is too much, then there is a high chance of this swelling up of the RK incision. They may also experience fluctuations in their refractive state for many weeks after their cataract surgery. So in all these cases, we should wait for at least 6 weeks and then give the final spectacle power, which is given along with the cylindrical power, depending on the number of the RK incision. Maybe we can wait for 2 months also post-operatively. And if the patient is still significantly hyperopic, we can plan to correct the residual refractive error, as in this particular case, which was a 48 years old female with the post-RK surgery, and surgery was done elsewhere. The surgery was immaculate, and no problem was there. After a few months, she came to us. 8 months later, the residual refractive error was plus 8.5 diopters with plus 3.5 diopters of cylinder. So we planned a Salcopix lens of a non-toric type of 12.5 diopter, and the post-operative refractive error was still was plus 1.5 with minus 3 diopters, and the patient was satisfied. And then we did the other eye and by using this formula, which wherein she didn't had too much of a residual refractive error. This is the Selco-fixed lens, which is a convexo-concave lens with a four-loop type. So the stability is better, and convexo-concave means the anterior surface is convex and the posterior surface is concave. So there is enough space between the pre-existing convex lens and this new lens which is placed in the sulcus. And I'm just polishing the posterior capsule, removing all the viscoelastic from between the space of the two lenses. You can use a toric lens also, because these lenses remain stable post-operatively because of the design which it is. To conclude, one should prefer single focus lens implants. Multifocal or trifocal lens implants should better be avoided because of their significant corneal abrasions which are present in the post RKI, and we should implant a negative spherical abrasion which gives us the maximum negative spherical abrasion, which is preferably Technis platform from J&J. I don't have any financial interest, and because this will utilize the positive spherical abrasion which are induced by the RK and the myopic laser vision correction. But in hyperopic laser vision correction patients, we should avoid using aspheric, or maybe we can use a zero spherical aspherical lenses, which doesn't change any spherical abrasion. And these are the better choices in these patients. RK corneas often induce large amount of positive spherical abrasion, as I have already said. We should use active fluidics. Low parameters phaco is preferred. Multifocal IL should better be avoided for the reason that the cornea is irregular. There is a high spherical abrasions. It is difficult to achieve absolute or near emmetropia, and fluctuation of the refraction also can lead in the fluctuation of vision. So patient satisfaction is not as good, and there may be progressive hyperopic shift in post-RKIs. I thank you for your patient hearing.
Thank you so much, sir, for the wonderful talk. I would like to ask you one question. When do you plan a toric IOL in post RKIs?
I plan it when the astigmatism is stable for long. If there should be an history, and there is no change in astigmatism axis and the power both magnitude both, and for last 1 year. In such cases, we can plan the toric lenses, and they give very good result, and that is a wonderful choice.
Thank you so much, sir. I would now invite Dr. Mahipal Sachdev to enlighten us with his journey with ELITA, the next generation lenticule extraction.
Thank you very much. Are my slides visible?
Yes, sir, they are visible.
Okay, fine. So I'll be talking about my journey with the ELITA platform. And this is something that we have been working on. The first ELITA machine we used in 2018. Now, if you look at the ELITA can be used presently for the flap as also for the lenticule. And if you look at the journey of the laser vision correction, the first generation of LVC was the PRK, and it was successfully done by Dr. Margaret MacDonald in 1987. And it was only Pellicaris in 1990 that he started the LASIK procedure that was there. The first procedure where only a pure femtosecond laser was used was done by Secendo in 2007. And then subsequently, the way SMILE is done today was done by Rupal Shah in 2008. The market introduction of SMILE was in 2011. And then obviously, after SMILE, there have been other laser platforms that have come to work. So this was 2007 when the keratolenticular extraction, as the lenticular extraction is called today, was done. Now, for the first time, we fired the ELITA in 2018, and this was for the flap. This was pre-COVID, and we looked at doing the flap, and there were the uh, the side cut which was there, and then there was the flap cut which was there. Ever since there have been a lot of changes, we have reversed the whole thing. We have gone on uh, to the uh, to the flap first, and then doing the side cut. Then when we looked at the performance of the first silk procedure, as it is called, that is the lenticule, uh, that was done on 4th of January, the first time in 2020 all over the globe. Now, this today, when you are looking at the lenticule extraction, there are several machines which are giving the lenticule extraction, but only in 2023, the nomenclature has been changed to CALEX, and CALEX is the nomenclature which is standing for keratorefractive lenticle extraction, because every company has their own name. So like LASIK is a gold standard as a name. Similarly, for the lenticule extraction, we now have CALEX as a name that is there, which has been accepted jointly by several people. Now let us look at the way the ELITA femtosecond laser works, and the laser is called as the lenticule process is called as silk, and the company wishes to call it as smooth as silk. Now, when you are looking at the lenticule that is created in the Alita platform, what you have to see is that this is basically the first of the biconvex lenticules that have come out. And the biconvex lenticules are essentially giving you better quality of vision. Now, what has it also done is that it is giving you a faster rep rate and with a small size. So there is minimal tissue disruption in the stroma. You have the optical zone, which you can vary. The minimum that we keep is about 6.2 millimeters, but you can go up to 7 or whatever you want. And you have an entry incision, which can be 2 to 3 millimeters, which is there. And the overall zone, which includes the transition zone over and above the optical zone, which is there. Now, when you look at a comparison of Alita with the IFS system, that is the interlace system, which is by the same company, the pulse duration is gone down to only about 100 femtoseconds, from 600 to 800 femtoseconds. However, the pulse frequency has gone up to 10 megahertz from 150 kilohertz, and the spot size has gone down from 3 microns to 1.3 microns. If you look at the Zeiss platform, the spot size is normally about 4 microns. The wavelength is about the same, obviously. And this you can see with the comparison that because the pulse duration is very short, so the total amount of energy that is delivered is only 40 nanojoules. So this is again a comparison between the Visumax, the earlier Visumax. This is not with the Visumax Pro. The pulse duration is 220 to 580 femtoseconds. IFS is 600 to 800. And you can see that this is the briefest of the pulse which is there, which is 130 to 170. Now, the pulse is, as I told you, about 1 microns. And because it is 1 micron, what has been done is that there is no line or spot separation. And this allows for a very easy dissection, which is there. The amount of energy that is released onto the cornea is also very less, and you get a tissue-free bridge lenticule extraction. When we started these studies, what has done is that we have reduced the energy level which we were using from 53, 54 nanojoules to now I am using about 36, 35, 36. So what this does is that it leads to clearer cornea and faster recovery of vision. Just to tell you that if you have larger spots, you can see if you are cutting a paper, or if you have smaller spots, you can see that this separation is going to be like bridgeless and much easier as compared to a more difficult separation when you are having larger spots of the femto. Now, therefore, as of now, this is considered to be a next generation lenticular procedure. You can treat up to 12 diopters or 36 diopters of cylinder, but a total has to be minus 12. So that means that you can have a combination of minus 10 with minus 2 cylinder, or you can have minus 8 with minus 4. So total is about 12. And this is what you can you can treat just now. and the biconvex lenticule is created only in 16 seconds of laser time. Post-docking, you can have centration and cyclotorsion adjustments that can be done, but it is manual as of now. You have to mark the center and you have to mark the axis to be able to do a cyclotorsion adjustment. This is just a comparison of the various kinds of lasers that are available, the Visumax, Visumax Pro, then you have the Zemer, you have the ATOS, Schwind, and the Elita. And all these lasers are currently commercially available, and all of them are available in India. Now, this is just to show you that this is the grabber that you have, and you can see here, this is the marking that has been done before. So you have the suction. Those who have used the intralaser, it's similar. You can see that this is the outside cone. And as you go in, you can actually go down onto the onto inside the grabber. It's a silicon tip. You go onto the grid area, you press the outside of the grabber, and you get a full applanation. Once you have a full applanation, which is there, you will then do the cyclotorsion adjustment and the centration. So you can see here the cyclotorsion adjustment that has been done, which is a 3-degree cyclotorsion adjustment, which has been done. So this depends on the marking and what you have. Once that is ready, this is the entry wound, which is 3 millimeters, total 7.4. You can see this is the undersurface where the laser is firing. This is the outside of the lenticule. Then this is the top surface that is coming. And then you have the entry wound, which is there. So this is pretty much the end of the procedure. As you can see, this is how it looks at the end of the procedure. These are the pieces, which one piece which goes below the machine, and this is the other grabber which is there, which this goes onto the machine to get a suction, and this is how you have the grabber going onto the eye. This is again, I'll just show you. You can draw. You can put a mark with the one eye, and there that is for the centration that you can look at. Now, just to show you the ease of dissection, you can see this is the entry. Because it's a biconvex lenticule, you just need to go a little bit higher, like a football kick, and then I use only a blunt spatula. I don't use any dissector, which is having mildly cutting edges. So this is just a blunt spatula, and you can see because of the 1 micron spot and no line and spot separation, you can easily separate out the lenticule. That is the anterior part, and now you can see we go into the posterior. That is the posterior part of the lenticule that we are dissecting. Again, very easy. You have some resistance at 3 and 9 o'clock, but that allows you to have the lenticule not roll over on itself. So this is now just the lenticule being pulled out, which is visual acuity
Recording
and
in
the best
progress.
corrected spectacle visual acuity. And we measured it for up to 1 week, 1 month, 3 months, and 6 months, and 9 months, and 12 months. So if you look at the study results which we have, the surgeons have rated the ease of lenticule extraction as no or mild dissection in almost 85% of the cases. You could see some resistance, that is moderate resistance, in 13%, and significant dissection was required only in 2%. We achieved uncorrected 20/20 or better in 100% of the eyes at 12 months, and you can see a steady improvement of the vision as you look at from the best corrected visual acuity over time and uncorrected visual acuity. You can see that that also is going up to. So far, after the study has been enlarged, we have had to retreat only 3 patients of the over 1,000 patients that we have done with the SMILE. And the MRSC within plus minus half a diopter, this is from emetropia, you can see 94% of the patients fall. Now, this was the intended and achieved MRSC that we were getting. We were getting a slight undercorrection in all lenticule procedures that you have. So we actually tightened it. And when we tightened it, you could see that the outliers which were here, they reduced. So in tightening, what we have done is that we do a slight overcorrection, which is 0.25 diopters addition to the minus power and plus 5% of what is above the power that is there. So if you have a -1, it will be 0.25 plus 0.1, and that will be 0.35. So similarly, you have this overcorrection. Easy and smooth lenticular removal was seen in almost all the cases, and 91% of the cases you can see required little or no dissection, which was there. moderate dissection in 9%, and no dissection in 4%. We get good clear corneas day one, and with the reduction of the energy and a slight reduction in the applanation pressure that we are putting on the cornea, we are getting almost all cases within 6.966 on day one. These are the results which have been published in Clinical Ophthalmology. And now I think there are more than 120 or 150, I don't know, the number keeps increasing, commercial installations across the world. It has still to get FDA approval, but it is all over in Asia, and it has got the CE mark. So my personal impressions along the journey have been that it lives up to the name of silk, with having a bridge-free dissections with minor or no tissue adhesions. All cases have had a complete lenticule removal except in two eyes, which were done by somebody else very recently. And there were no cold spots or uncut areas. So for beginners or for those people who are joining in, keeping the cornea unexposed, you shouldn't keep the cornea exposed for a long time to the waft of air or to the AC or whatever, because that if there is dryness on the cornea, and you are applanating on a dry cornea, that's when you get the cold spots. So better to have the cornea moistened before you start the procedure. And once you have that, that is the cold spots will not be there. There has never been a difficulty in the entry cut because it goes over it several times. Plane identification is also relatively easy if you are looking at going into the proper plane. Corneal biomicroscopy was unremarkable. Fast visual recovery is something that is happening. Obviously, once you have reduced the energy, you have titrated. Remember, any machine has a grass burn threshold, and you have to work according to the GBT of the machine and do bring down the amount of energy that you are using so that you get a good dissection without compromising on the dissection. You have to actually keep reducing the energy. The outcomes have been tight, and the accurate refractive corrections, we don't still have it for hyperopia, but we can do even pure astigmatism but you have to just mark it properly and do the cyclotorsion adjustment. Patient satisfaction has been good, and we have been using this ELITA technique for silk ever since 2020. And this is, I would say today, a generational leap in corneal refractive surgery, which gives us exceptional precision and accuracy with outstanding patient outcomes and highly, also I didn't mention, but when we did the flap study from 2018 onwards, and we looked at the OCT and the thickness of the flap, their standard deviation was less than 5 microns. So flap thickness is also excellent, and the stromal beds are very easy to lift, and they are of outstanding quality. So I think with that, I'll just wish to thank RP Center for having invited me for this CME and educational program on the Founders Day of RP Center. Thank you very much for your kind attention. Thank you.
Thank you so much, sir. So, what is your experience with high astigmatism in
Oh, I
such
have
cases
had
with silk?
I have excellent. See, the only problem that was there earlier was that when you were looking on the Visumax, you were not compensating for the cyclotorsion. That was the only thing. If you have marked it properly, the result, see, it's the Mundrin formula that you are using. So whether you are doing an excimer ablation or you are doing a lenticule, the results would be the same. They are not going to be different from that point of view on astigmatism. The only thing is the cyclotorsion compensation has to be done. Though it is manual just now, it's going to be associated with the eye design, and it's going to be automatic. I have even with the manual one, I'm getting excellent results. You know, for toric IOLs also, if you're placing, even though you may not have a Callisto or a Varion, but if you are doing a marking which is accurate, you can still get excellent results. So it's the same for here, and we have good results in silk for lenticule extraction, for astigmatism.
Thank you, sir. I would next invite Dr. Namrata Sharma for her talk on recent advancements and technologies in EDOF IOLs.
Thank you, Akshara. Am I audible?
Yes, ma'am, you're audible.
So I would be primarily talking about the new lens which has come in, that is the Technis Pure C intraocular lens, which has come from Johnson and Johnson, and it does help to redefine the vision needs. And the best part is that it is purely a refractive design with high quality of vision, easy to use, and it has come on a Technis 2 platform. And we do also have toric intraocular lenses now. Uh, we know that the patient now has activities which are not only related to distance and near, but also intermediate. And this lens actually allows for the distance as well as intermediate and the functional near vision. So it gives a continuous, crisp, and clear vision. There are low levels of disturbing visual symptoms, and it gives good vision during the day as well as by the night. It is purely a refractive design. There are no rings there. Gives high quality of vision. It is easy to use, and it provides excellent, like I said earlier, distance, intermediate, and a functional near vision. Because nowadays, as we all know, it is the intermediate and the distance which is more important as compared to the near. So if we look at the picture here, this is how you would see with the Technis Pure CIOL, which is very much comparable to the monofocal intraocular lens, and there are no dysphotopsias at all which are seen. And this gives the range of vision which is there, excellent distance, intermediate and near functional vision, as can be seen in the graph. And like I said, that the design, I think it is the lens which has purely which has got a purely refractive design. It does give more than 35% higher image contrast than the other EDOF lenses and less pupil dependency. To provide similar mesopic contrast level compared to the Technis AIIMS intraocular lens. And this is the quality of vision, the 3-month mesopic vision with no glare at all. And with this lens, which can be seen in the spatial frequency chart. And then it also provides superior distance image contrast and less pupil dependency, as can be seen in this figures. The MTF, notice there are 3 millimeters and 5 millimeters, both is good. And apart from this, the patient satisfaction is very high, and even in the I think the best part is that it comes in loaded platform, so you don't have to actually load it. The delivery system is quite friendly. It is a screw kind of a delivery system. Today in the morning from the RP Center OT, we had 2 cases of Pure C which were done. As far as we are concerned, we have a follow-up of now more than 30 eyes, and we are a part of the multicentric trial for which I think Dr. Mahipal Sachdev Center, Dr. Ramamurthy Center, ourselves, and Sri Ganesha Center. These are the 4 centers which are part of this multicentric trial. Now, this is just to show the dysphotopsia profile even under the defocus. And if we compare it with the other platforms, it is quite similar. If we compare it with Symphony IOL, it is much better. Important thing is that the clinical study, first clinical study which was done and which is published, did show that there's a high patient satisfaction to the order of 88% of the patients who were satisfied with their vision overall without glasses, and 100% of the patients did not need glasses for distance, and 97% of the patients would recommend the lens to their friends or to the relatives. And like I said, the injector system is very simple. You can just, it comes in a preloaded format, so you have to hydrate, advance, and deliver the lens. Because of it being preloaded, there's hardly any chance of infection. It eliminates the manual loading errors and also the IOL touches. It has frosted haptic design, which increases the amount of friction between the lens haptic surface and the capsular bag to lock in the IOL for rotational stability as well as for visual performance. This is how this is what the characteristics are. It comes in various ranges of power, and like I said, the toric intraocular lens is also available now. So thank you very much for your kind attention, and I do think that it is a lens of future, mainly because it doesn't have any rings. So it is a lens without any rings, and it also does not have any dysphotopsias. So, Akshara, I also have another talk which have to be given. I think I will just finish that also in 5 minutes. So,
Yes, ma'am. Thank you so much, ma'am, for your wonderful talk. I would next invite Dr. Amit for his talk on pearls for bleb needling.
just 1 second, Akshara, I have to take this talk as well. This is the sponsor's talk, so I will quickly just finish this also.
Yes, ma'am.
This is a paradigm shift in the IOLs and the injector system, and I think we are talking the lenses from the Hoya, the Vivinex lens, which was again implanted in the live surgery today done by Professor Rajesh Sinha, and the glycerin-free hydrophobic IOL material, which is there, which can be seen as we compared it with the other competitive lenses. The rate of the glistenings with these lenses is much less. It's hardly any. We've not reported, at least in our cohort, we've not seen any glistening. And it has a rough frosted haptic. So again, that allows for better apposition with the capsule. It has proprietary aspheric optic design, which neutralizes the corneal positive aberration, tolerates anatomic misalignment, and compensates for the coma aberration as well. And the surface treatment is there. Is completely prevented, as can be seen here. Operational stability, like I said earlier, is very good because of extended from the Hoya. You also have Impress, which is which also provides good acuity. Geometric diffractive, again a lens which gives good visual acuity, although it has got rings, but the range of the vision is quite good. And the point spread function also shows low light scattering, and it is optimized to suit the different lifestyles. As far as the IOL are concerned, the IOL is of a great quality, but I think more important is the injector, because it comes as a preloaded injector, and I think it is one of the finest injectors which the Hoya has manufactured. And we have all the options: one-handed push injector, two-handed screw injector. Then it can be delivered into the capsular bag, or it can be delivered through the incision as well. And the steps actually of the injection are written on the injector itself. So you put viscoelastic as step 1, release the tabs and the cover, then take out the whole assembly, and then it is ready to go. As far as I would just like to show you the video of the same. So this is a case in which we plan to put the lens with this inserter. This is a preloaded device. One is written here, so you have to put the viscoelastic here. Once you put the viscoelastic, then this tab and this side cover has to be removed from here, where 2 is written, and then subsequently the whole assembly is picked up, and then the injection, like in this case, is being done into the capsular bag, but you can also do a wound assisted injection. So I think incision distortion, it doesn't cause much, because it can go through as small as 1.7 millimeter incision. And I think this is again a great system. So thank you very much for your kind attention.
Thank you so much, ma'am. Next, we have Dr. Amit for his talk on pearls for bleb needling.
Akshara, my slides are not able to share. Can you tell the backend admin to allow me to share the slides?
Try
Hello?
1 second, sir.
Yeah.
Yes, so your slides are visible.
Is it visible in the slide mode? Yeah.
You need to click on the slide view. Okay,
Done?
it's visible.
Yeah.
Yes.
So thank you, Akshara and team RPC, for inviting me for this scientific session. So I'm going to talk on pearls for bleb needling. So when to do bleb needling, basically when you have a fade bleb and encapsulated hydromorphosis bleb, or when a bleb is flat and localized. So the goal of the needling is to re-establish the fistula from the entry chamber to the subconjunctival bleb, where aqueous humor may be reabsorbed. It was first described by Ferrari et al. In 1941, and needling revision with MMC was described by Mardelli et al. In 1996. So coming straight to the procedure, it can be performed in the OPD or OT. This is always a debatable issue. Preoperatively, topical anesthesia, betadine drops and antibiotic drops are administered. You have to put a wire speculum. Then with the help of a 26 to 30 gauge needle on a tuberculin syringe, which is mounted, and then needling is proceeded. So you can see this is a small video which I'm showing. The patient had an encysted bleb. I'm doing this in the OPD on the slit lamp. This needle is passed 5 millimeter away from the bleb laterally, temporarily, and then with the to and fro cutting motion, all the fibrous septa which are there, I'm cutting it out. And you can see as I'm cutting it, the bleb is being formed. You can enter into the antechamber also through the internal ostium if the bleb is not being formed, so that the whole needling procedure is accurate. Now, at this point, you should not stop just the moment you get the bleb. You have to make sure that you go to the other side of the bleb also, that is the nasal side also, and cut out the fibrous band so that you have a diffuse bleb. You can see the patient has to be very cooperative throughout the procedure. There can be some bleeding, but nothing to worry about. It can be controlled. This is the pre-bleb needling photograph at the bottom, and post-bleb needling, the diffuse bleb. This is another procedure being performed into the OR. Basically, after in topical anesthesia or after giving a peripulbar block, corneal stay suture is taken. The eye is depressed down, pulled down, and to expose the bleb area. You can see this is a flat vascular bleb. 0.1 ml of 0.02 milligram per 0.1 ml of mitomycin is injected subconjunctivally as much posteriorly as possible. Whatever mitomycin escapes anteriorly, you just have to iron out or brush it out gently posteriorly so that you don't have the mitomycin escaping into the antechamber and mitomycin toxicity. So after a holding period of about 3 to 5 minutes, then you can take a 26 gauge needle, bend into an L shape. You can see I'm entering into the subconjunctival space about 5 millimeters away from the lateral margin of the bleb. With the to and fro motion of the bevel edge, I'm trying to cut all the fibrous septae. Try to avoid the vessels as much as possible, but this was a vascular flat bleb, so there will be some chances of bleeding. You can see that I'm cutting all the fibrous septa. Now I'm going to the other side of the triangular flap, which I always make. You can see the bleb is formed, and now I enter into the antechamber to the internal ostium, and you can see the aqueous is seeping out, and the bleb is nicely being formed. Sometimes when you at this procedure, you can see that the AC becomes shallow. Nothing to worry. Make a side put incision, and you can do stromal hydration also to check the patency of the bleb of the internal ostium and whether the bleb is being formed or not. So the important point is you have to make sure that you cut the fibrous septa both temporal side and the nasal side of the bleb, and also as much posteriorly as possible. In this case, you see the AC became shallow. It is soft now, so I made a side put incision, and I'm checking the patency of the internal ostium by doing stromal hydration and also AC hydration. So the bleb is being formed, and you can close the wound with the help of stromal hydration, and then you can start post-operative or routine post-operative medications. So this was a picture of this particular patient in the OR, which I did. It was a flat bleb, and after the needling, you can see a diffuse bleb, and this is at the end of 6 months, how diffuse it looks. So there is another procedure called ab internal needling. In this, what happens is basically you take a corneal stay suture. Sorry for the poor quality of the video. You take the corneal stay suture, inject mitomycin as told before, away from the bleb as much posteriorly as possible, dose being 0.1 ml of 0.02 milligram. Brush out the mitomycin posteriorly so that you don't have the toxicity of the mitomycin. Take a side port incision. Now, once you make the side port incision, you can inject sodium hyaluronate, that's the preferred viscoelastic. Now, with the help of this long iris spatula, you can just go from the side port into the internal, towards the internal ostium with a to and fro motion. Try to go subscleral flap and then into the subconjunctival flap. You can see throughout the tip of the instrument should be visible. In this, you can see it is visible in the subconjunctival space. Try to separate all the subconjunctival tissue. You can try it from the other side also. You can do it with a long spatula or this grower spatula, which is available for this procedure. You can use that spatula and do it. But what I usually do is I do with a long iris spatula, and it serves my purpose. So ab internal, ab external, both you can do. You can check the patency now by doing AC hydration. You can see that the bleb is being formed. So post needling changes the appearance of the bleb. Antibiotic steroid drops, digital massage, and needling can be accompanied with MMC or 5FU. It can be given superior temporally, as I mentioned before. So blebs with thick scar and quick failure use MMC, while those that succeeded longer and failed slowly may respond adequately to 5FU. Complications, there can be was I audible? I think I got disconnected.
Yes, sir. You just got disconnected now.
Just
Can
now,
you?
is it?
Yes, just now.
So I think the last two slides only. So yeah. So So complications of needling, there can be intra-bleb needling, buttonhole, bleb leaks, hyphema or hypotonic is the most common complications. And the rare complications being endothelial toxicity, choroidal effusions, suprachoroidal hemorrhage, endophthalmitis, and again filtration failure. So how effective is bleb needling? It is more effective performed within 4 months from the time of trabeculectomy. It is less effective if the pre-needling IOP is greater than 30, immediate post-needling IOP is greater than 10, or when TRAB is performed without MMC. So key points for needling is factors such as the time period after the initial TRAB and the degree of scarring will greatly affect the outcome. Varying success rate ranging from 30 to 94% have been reported. It is repeatable procedure with minimal risk in the management of glaucoma patients. It avoids the risk of invasive surgery as well as the need for daily medications. Needling a previously viable bleb conserves the conjunctiva and allows faster recovery and fewer complications than repeat TRAB offer visible results. So always try to revive the old TRAB site with the help of a needling. And this is all I wanted to say. Thank you.
Thank you so much, sir. I would next invite Dr. Rajesh Sinha for his talk on managing astigmatism with new age toric IOLs.
Thank you, Akshara. Amit will have to unshare first.
I have stopped sharing my screen.
Yeah, please.
Yeah. Is it fine?
Yeah, it's absolutely fine. So thanks a lot, Akshara, for what's happening there? Yeah. Okay. So I would just like to talk about how things have evolved over time as far as the intraocular lens is concerned, as far as correction of toricity of cornea is concerned. I don't have any financial interest. But whatever we have done so far in our life, in our career, this man has to be, either blamed or given credit to what all we have done. Sir Harold Ridley, who first created controversy when he put the first intraocular lens, but then it became the standard of care, and things evolved over time in terms of material, in terms of design, in terms of delivery system, and things have moved so much that targets have started changing. The first target was to achieve the uncorrected visual acuity of 6/6 or 20/20. The next target was to achieve good vision for near as well, because people used to tell that we still need spectacles for near correction. And then the next target was to achieve good vision for all ranges. So for initially, for distance, and then came bifocals or multifocal lenses, which gave some good vision for near as well, but had a lot of glare and halos and starbursts, etc. And there were a lot of patients who are not suitable for multifocals, like diabetic patients who have any kind of a media haze, etc. And then there was some problem as far as intermediate vision is concerned. So for all these reasons, things changed in such a way that people wanted visual acuity, good vision at all range, at all distances. And that's how came these EDOFs and the enhanced monofocal lenses. And the first enhanced monofocal lens that became very popular was Tecnis AIIMS intraocular lens. And it looks just like a Tecnis monofocal lens. There's no difference, there's no ring, there's nothing like that. But it does provide a good distance vision and provides a reasonable intermediate vision, which gives you a good option of reading, watching TVs, watching laptops. You can play cards, you can do all your daily activities with a reasonably good intermediate vision, particularly when implanted bilaterally. And there was no photic phenomenon because the visual quality was same as a monofocal lens. But then again, there was an issue that, as in monofocal lenses, we had toric implants. So similarly, people started thinking that if we are implanting these enhanced monofocal lenses, cylinder also has to be taken care of, because if you don't correct the cylinder, the clarity of vision is not good. It will be something like this. You don't get this crisp vision as you can see on the top. So that's why further evolvement was done, and then was launched the Tecnis AIIMS Toric 2 IOL, which is on the Tecnis platform only, but it has a squared and frosted haptic design. Now, if you have a toric implant, then in that case, there are a couple of things. One is that you should mark well, because when the patient lies down, then the marking is not correct because there's a cyclotorsion. So you have to mark the patient when the patient is standing in front, sitting or standing. So a bubble marker is a good tool which is used very often by most of us. And this lady, you ask the lady to stand just opposite a wall so that her head is straight. And then you can dry the inferior surface and then use the bubble marker, mark it, and use the bubble marker to mark the 3, 6, and 9 o'clock position. There are other ways of marking it. You can directly mark the 6 o'clock, 3 o'clock, and 9 o'clock position. You can use a thin slit beam of a slit lamp, and that's how you can mark. There are markless methods like Callisto eye, which we use very often in the morning. I had implanted a lens wherein the Callisto eye was used. Virion digital marker, and of course, OptiWave refractive analysis. So these are all markless alignment, which can be used to align the toric lens in appropriate axis. So this is a simple method wherein marking has been done. The axis has been marked. 0, 180 degree is marked when the patient is standing, and then the axis, that is the reference axis. And the axis wherein you have to align the lens is marked once the patient lies down. And this is the axis. You inject viscoelastic, go ahead and complete the procedure, complete the nuclear emulsification. And this is the AIIMS toric IOL, which is a preloaded lens, which comes in this cartridge. This is how it looks like. And it can be implanted through a 2.4 millimeter incision very easily. This is a screw system. That is why you need a 2.4 millimeter incision. So normally you use 2.2 millimeter incision for a cataract surgery, and then you just make it 2.4, and then you inject the IOL. As it is a screw system, it doesn't go with a jerk. It goes slowly, and then so you don't have a risk of any complication by accidentally putting the IOL in a jerk. Once you have implanted the lens, you should remove the viscoelastic from the back as well as from the front, because for a toric lens, for any lens for that matter, you should remove the viscoelastic from back as well as from front. But for toric lens, it is mandatory, because if there's any viscoelastic left, it can cause postoperative rotation. And once you align it in position, you hydrate the bone, and that's the end of the procedure. So this is how it looks like, the frosted design that has come up now. And this frosted haptic and squared edge haptic, this adheres with the capsule very well, and that is how it doesn't rotate. It has a very good rotational stability as shown in various studies. So in conclusion, the AIIMS lens is in the Technis platform. It is a monofocal lens with some degree of defocus. It provides some intermediate vision, and when implanted in both the eyes, you will have a very good intermediate vision. You can use your laptop without use of any glass. And of course, there's no photic phenomenon because it is just like a monofocal lens. There's no splitting of light. And it can be used in eyes which are not suitable for multifocal lens. And incorporating cylinder in this platform has really improved the outcome, and it has a good rotational stability because of the frosted squared haptic, and thereby it improves the quality of life of the patient. So thank you very much once again for this opportunity. Thanks, Akshara, for moderating the session, and thanks everyone for being a part of this session. Over to you, Akshara.
Thank you so much, sir. Sir, I would like to ask one question. So, what is your take on toric IOLs in post-LASIK cases?
See, in post-LASIK cases, you can still go ahead and put a toric lens. But in a post-RK, I would like to avoid, because in post-RK, particularly when there are too many incisions, 16 incisions, and even more than that, there's irregular astigmatism. So these patients, they do very well by masking their irregularity by RGP contact lens. So better to put a monofocal lens without any cylinder. But in a post-LASIK one, you can still go ahead and put a toric lens, and it works well.
Thank you so much, sir. Thank you everyone for joining the session. Thank you so much.
Thank you. Thank you, Akshara.
Recording stopped.